I would like to welcome everybody on behalf of Stanford CME to the Overcoming Key Barriers to Healthcare Provider Adoption of AI Tools. I will turn it over to Dr. Sattler to moderate this session.
Hi all, welcome. We're so excited to have you, and it is my absolute pleasure to get to introduce you to our esteemed panelists. We have Mark Sendak, who's coming to us from Duke. He is in the he's the Population Health and Data Science Lead at the Duke Institute for Health Innovation, where he leads interdisciplinary teams of data scientists, clinicians, and machine learning experts to build technologies to solve real-world clinical problems. He also co-leads the Health AI Partnership, which is a learning collaborative that advances the safe and responsible use of AI software within health systems. And together with his team, he's integrated dozens of data-driven technologies into clinical operations and is a co-inventor of software designed to scale machine learning applications and real-world evidence generation across health systems. He leads the Duke Institute for Health Innovation Clinical Research and Innovation Scholarship, which equips medical students with the business and data science skills required to lead healthcare innovations. We also have Dr. Stephen Lin with us today, who is a practicing physician, an educator and researcher, as well as a health system leader in the specialty of family medicine. He earned his medical degree from Stanford University School of Medicine and completed his training at Stanford's Family Medicine Residency Program. He's Stanford's Family Medicine Service Chief, Head of Technology Innovation for the Division of Primary Care and Population Health, as well as the founder and executive director of the Stanford Healthcare AI Applied Research Team. His research focuses on the intersection of health services innovation, digital health, and emerging technologies, specifically in the areas of artificial intelligence and machine learning in healthcare. Dr. Lin is currently a James C. Puffer American Board of Family Medicine Fellow with the National Academy of Medicine and is the author of over 350 scholarly works and conference presentations. We also have with us today Andrew Gonzalez, and Dr. Gonzalez is a vascular surgeon, an assistant professor of surgery at Indiana University, where he is working toward his early career goal of building a data ingestion, analytics, and curation platform that facilitates rapid development and deployment of end-to-end AI/ML models using multimodal real-world clinical data. His current work is centered around two broad areas of inquiry. First, in using real-time computer vision algorithms to enhance provider workflows for endovascular treatment of peripheral artery disease. This is the leading cause of amputation in the United States. Second, he's developing a multi-scale network theory-informed framework for chronic disease care delivery. We also have with us Dr. Cornelius James, an assistant or clinical assistant professor in the departments of internal medicine, pediatrics, and learning health sciences at the University of Michigan Medical School. Dr. James was an inaugural 2021 National Academy of Medicine Scholar in Diagnostic Excellence. And as a NAM scholar, he developed the data-augmented, technology-assisted medical decision-making curriculum. The curriculum is designed to teach healthcare professionals to use artificial intelligence and machine learning in their diagnostic decision-making. His research interests include clinical reasoning and implementation of digital tools into clinical practice. Our final panelist is Barbara Evans. Barbara Evans is a professor of law and a Stephen O'Connell chair at University of Florida's Levin College of Law. She's also a professor of engineering at the University of Florida's Herbert Wertheim College of Engineering. Her work focuses on data privacy and the regulation of machine learning medical software, genomic technologies, and diagnostic testing. She holds a Bachelor's of Science in Electrical Engineering from the University of Texas at Austin, a Master's and PhD from Stanford, and a JD from Yale Law School. She also holds an LLM in Health Law from the University of Houston Law Center, and she completed a postdoctoral fellowship in clinical ethics at the MD Anderson Cancer Center. So with that, I would like to introduce today we're going to have each of our panelists give a brief 5-minute presentation and discussion. And after that, we're going to open it up to a formal discussion as well as be open for questions and look forward to answering the questions that you have. So please utilize the chat during this session. So with that, I'd like to invite Dr. Stephen Lin.
Thank you, Amelia. So hello, everyone. Today, I'm going to be serving really as a appetizer to the main course that will be my esteemed colleagues and co-authors of this recent National Academies of Medicine Perspectives paper on addressing barriers and facilitating clinical adoption of AI and medical diagnosis. Our paper was written as a companion document to a technology assessment report on AI by the US Government Accountability Office, which was developed with the purpose of providing guidance to Congress. In our paper, we acknowledge that AI-based diagnostic decision support tools, or AIDDS, have broad potential to revolutionize the field of medical diagnostics. However, they will fail to achieve wide uptake if there is insufficient clinical acceptance. So for the next few minutes, I will present our framework, which you see there, for considering and overcoming key barriers to adoption centered around reason, means, method, and desire to use these tools, which my colleagues will then build on in their presentations. Our framework drills down into the key factors related to the successful adoption of AI-based diagnostic decision support tools in both inpatient and outpatient settings. The issues are organized into 8 major determinants across 4 interrelated core domains, as you see there. This framework was really derived from our understanding of human and system behaviors in response to the introduction of new technologies, as well as our collective experiences deploying AI at our institutions. Domain 1, reason to use, explores the alignment with healthcare missions, incentives, market forces, and reimbursement policies that drive healthcare investment in AI diagnostic decision support. Is the purpose of the AI aligned with the right values and priorities of health systems, providers, and patients? Who pays for these tools and how? Dr. Cornelius James from the University of Michigan will weigh in. Domain 2, means to use, reviews the data and human infrastructure components, as well as the requisite technical resources for deploying and maintaining these tools in a clinical environment. What are the data and computing infrastructure required to collect and clean healthcare data, develop and validate an AI algorithm, and perform routine maintenance and troubleshooting of technical problems? What are the human and operational resources needed to conduct these technical functions so providers can actually interface with these tools? Dr. Andrew Gonzalez from the Indiana University will speak to this. And domain 3, method to use, discusses the workflow considerations and the training requirements to support clinicians in using these tools. How do you contend with the considerable heterogeneity of clinical workflows across and within organizations and develop new AI-based workflows in a way that reduce the cognitive burden on providers while minimizing distractions and clinical tasks? How should you educate providers to use AI in an already crowded training and certification ecosystem? Dr. Mark Sendak from Duke University will tell us how. Finally, domain 4, desire to use, considers the psychological aspects of provider comfort with AI, such as the extent to which the tools alleviate clinician burnout, provide professional fulfillment, and engender overall trust. This section also examines medical legal challenges, which is one of the biggest hurdles to fostering provider trust in and the adoption of AI. Dr. Barbara Evans from the University of Florida will help us think about these issues and better understand the current regulatory ecosystem. With that, I'll turn it back to you, Amelia. I'm really looking forward to a fantastic discussion today.
Wonderful. And next, I would like to invite Dr. Cornelius James, who's going to discuss with us reason to use, alignment, and incentives.
Thank you, Amelia. And I'd like to thank Stanford University and Dr. Lin for inviting me to be a part of this important conversation. And I also want to acknowledge that I'm honored to be a member of a panel that includes individuals that are doing truly amazing work in this space. So when we consider the reason to use AI, it may be helpful to phrase this as a question of why. It's often the why that drives individual or collective missions. Perhaps we should be asking, why do clinicians do what they do? Why should health systems and clinicians use AI? Or why would patients want clinicians to use AI? Or why should payers reimburse for the use of AI? When we consider the question of why, we may notice that value is a common thread for each of these stakeholders. Stakeholders must believe that AI-based tools add value to what they do. In other words, use of an AI system must align with their core objectives, stated goals, and their mission. And while stakeholders or different stakeholders may have different specific needs or strategic missions, many of these needs and missions are often centered on value. Value in healthcare can be measured using the value equation. Many of us are familiar with that. This equation includes factors like quality, which is measured by patient outcomes, safety, and service, and also cost. So the question becomes, how does AI contribute to this value equation? How does it impact patient safety, outcomes, and service? Is there a net increase or decrease of cost with the use of AI? When assessing the value of an AI system, it's also useful to think about how it impacts stakeholders' work toward the quintuple aim of healthcare, which includes better outcomes, better patient experiences, lower costs, better provider experiences, and more equitable care. So stated another way, an AI system can be measured by how well it solves problems. One of the most crucial steps in establishing the value of an AI tool is identifying an important and relevant clinical problem. A frequently cited example is sepsis. Sepsis affects millions of patients in the United States each year and contributes to thousands of deaths. When recognized early, sepsis-related morbidity and mortality may be decreased with the initiation of effective and timely care. It's easy to appreciate the value of a model that accurately predicts the risk of a deadly condition, even before a clinician identifies objective signs or symptoms of the condition. However, other factors must be considered when developing and implementing a sepsis prediction model, or any other model for that matter. For example, how does the model perform in real-world clinical situations? Does its performance generalize to populations that are different from those in which the model was trained on? Are the model outputs presented at appropriate times or displayed in a way that will allow clinicians to act quickly and decisively? We've certainly seen examples of models that address an important problem, and they've appeared to be effective during their training and testing, but they didn't perform as well in clinical practice or in diverse populations, which may have diminished its value. Closely related to the alignment of AI with missions of health systems and value are incentives and reimbursement. Recall that the value equation includes cost. If health systems and clinicians are going to adopt AI systems, there'll need to be a robust payment and reimbursement structure. This may prove challenging given that there are different payers, different potential payers in the US. However, historically, government entities like the Centers for Medicare and Medicaid Services have set the stage for reimbursing the use of new technologies, and quite often private insurers follow their lead. It's also reasonable to reflect on the impact that legislators and policymakers had on the widespread adoption of electronic health records, which provides a cautionary example. EHRs have certainly had beneficial effects on healthcare. Similar to artificial intelligence, there was a lot of promise and hype surrounding the use of EHRs. However, it is important to acknowledge the challenges with implementation of electronic health records and the burden that they placed on clinicians. It's interesting that prior to the Affordable Care Act going into effect, only 12% of hospitals had electronic health records. Now, approximately 96% of hospitals in the United States have electronic health records. So it's fair to ask if we will see an increased adoption of AI by health systems if they are incentivized or penalized by the government based upon whether or not they've adopted artificial intelligence. Given the focus on value, it's very likely that AI will be more readily adopted in a value-based framework that emphasizes patient outcomes, safety, and service instead of a fee-for-service framework that rewards volume more so than value. So ultimately, if clinicians are going to adopt AI, attention must be given to the value that it adds to patients, health systems, payers, clinicians, and many others that are involved in the care of patients. And attention must also be given to how AI is incentivized and reimbursed. Thank you.
Thank you so much, Dr. James. Now I'd like to invite Dr. Andrew Gonzalez to talk with us about method or means for use, infrastructure, and resources.
Hi, thank you so much. I really appreciate this opportunity to present and to participate in this panel. So in our section, we talked about two big areas. The first is infrastructure and the second is resources. But more broadly speaking, we can divide this into 5 key components to think of. The first is about the data. The second is about algorithms and models. The third is about software. The fourth is hardware. And the last is people, which is so important. We actually had its own subsection. As we move forward, we need to understand that this big data revolution and the dependence on AI algorithms is a fundamental change from what we've been doing in AI and diagnostics in the past. So there are a few attributes related to infrastructure, particularly with data and algorithms, that are important to keep in mind. The first is that everything is continuously updating, meaning the actual data updates. For instance, the Framingham model, once the model has been published, whether or not you package that as a journal article with some equations, or you package that in the form of an iPhone app, it doesn't really update except for when the panel revisits how they're going to do the model. But generally speaking, when you're using a production level AI model, the data updates automatically. In fact, this is generally considered to be a feature rather than a bug. Additionally, data types update as well. And it's very important to consider the fact that although now you may not be interested in looking at the raw data from chest x-rays, in a year or two, that might be something that your algorithm must be able to handle and model. Additionally, the algorithms themselves update. There are massive changes, particularly with respect to natural language processing, but also with respect to computer vision, that can fundamentally change the ability of algorithms to answer clinically relevant questions. And that gets to the last point, is that the clinically relevant questions can often change as well, meaning that with certain amounts and types of data, we can only address certain questions with any degree of efficiency and accuracy. But as we evolve and have more data, more institutions and more diversity, it's possible to address clinical outcomes of interest that were not perhaps thought of before. In this realm, I think it's very important to consider that flexibility is of very important paramount, particularly with respect to the systems and software that are able to be used. We have to build toward the future. I think it's important that people who are implementing these consider that we should prioritize platform and frameworks over, in particular, algorithms or outcomes. Additionally, interoperability is also a key process that must be addressed between systems. So for instance, Cerner and Epic, as well as over time, i.e. future-proofing. There are a number of pain points that can occur in creating these end-to-end pipelines, and we must consider for implementation that preventing clinicians from finding better value in workarounds is as important as developing the algorithms themselves. Finally, in terms of human capital, beyond the clinicians and teaching us how to appropriately use these systems, we have to consider the cost and pain associated with maintaining them, and whether or not that should be an in-house problem or it should be something that's outsourced to consultants. So thank you very much, and I look forward to the conversation.
Thank you so much, Dr. Gonzalez. Next, I'd like to invite Dr. Mark Sendak to discuss method to use, efficiency, and workflow.
So I couldn't stop looking at the pictures of Andrew's daughter, so it's hard to follow that up, but pleasure to be here and really appreciate the opportunity to not just have this conversation, but really excited for the Q&A that's going to follow. So 3 things I'm going to talk about. One is problem selection and how to align organizational stakeholders during the problem selection phase. Next is actually during workflow design. And then the third piece relates to more recent work that we've been doing related to capacity building across multiple health systems. So The team that I work for, most of our projects come to us through an annual request for applications. And this is essentially an annual innovation competition. And the way that this works is it aligns senior leaders with frontline worker problems to make sure that the projects that we invest personnel and resources into are well positioned for implementation and adoption. So every year, the process starts with identifying the strategic priorities from our senior leadership. These can be broad themes. These topics can range from provider burnout, safety at transitions out of hospital to hospital-associated infections. So we have the strategic priorities, those go out to frontline workers who are most familiar with the problems in the organization. They propose focus areas, and this can be sepsis, it can be peripheral artery disease, chronic kidney disease. And we don't get algorithm specifications, we get problems. And then we work with senior leaders to vet those problems. And then there's investment for 12 months. So definitely working up front to align senior leaders, business unit leaders, and frontline workers is essential for positioning projects for translational success. The second piece is when we actually get to the point where we're trying to design workflows, a common theme that has surfaced through qualitative research that we conducted this last year with Kate Kellogg at MIT, she's an organization studies scholar. What we did with her is we looked at our 15 AI ML model integrations, and we tried to classify every model as a success or a failure. And then we were able to facilitate interviews for her with project leaders on all of these projects. And a common theme that we identified, and I think is reflected in what we observe nationally as well, is at a place like Duke or high resource academic medical centers, it's very common to see downstream specialists. So this can be a nephrologist who is helping a patient who has recently started dialysis. It can be a vascular surgeon who is performing an amputation for a patient who's had untreated peripheral artery disease. It could be an ICU physician treating a patient who's developed sepsis. Oftentimes, the physicians or the clinicians who are most familiar with the problem are downstream of the point at which the disease needs to be recognized and intervened upon. So we get these proposals that often point upstream in the care delivery process. And it's often to primary care physicians or to emergency department physicians. So generalists who are often the front door for healthcare. And we have to work with those generalists to adopt technologies that ultimately may be creating value for other individuals in the organization. And this is kind of related to what Dr. James was mentioning earlier, Cornelius, was you have to think about who you're creating value for. So oftentimes we have to do some activity like value stream mapping, where we say, okay, if we're asking a primary care doc to do something different in the way that they identify these chronic conditions earlier, or something more intense in terms of how they intervene, we have to make sure that we also solve problems for them. We can't just ask these primary care docs to take on more work to create value for downstream stakeholders. So we often spend a lot of time bringing together the specialists and the generalists, upstream and downstream labor forces, and identifying where can we create value across the spectrum and solve problems across the spectrum, because it's unfortunately very common to just go to primary care or go to the emergency department and say, well, you need to do more to treat this condition. And so we've had to kind of develop tools and tactics to facilitate that. And then the third piece I'll talk about relates to a program that we started this last year called Health AI Partnership. And this relates to how do we prepare and educate both clinicians and operational or administrative leaders for adopting these technologies. So even on this call, we have folks from institutions across the country. And the reality is, within every one of our organizations, we're often asking ourselves similar questions. We're asking ourselves, well, is an in-house solution better or worse than vendor solutions on the market? When we're considering a solution, how do we assess for potential bias or discrimination or impact on inequities? How do you monitor model performance over time? How do you update models? So what we're doing through Health AI Partnership is trying to surface best practices from across a dozen health systems across the country. So we've conducted over 75 interviews, and we're in the midst right now of developing kind of the first set of online material and workshops that are mostly case study driven, because we have identified common decision points and questions that people in different contexts are already building expertise answering. But unfortunately, there's not a lot of the communication channels and visibility so that a site like Duke really understands, well, how did UNC 8 miles down the road evaluate their vendor solutions? And is there something we can learn from that because we have a similar population? So trying to create that community and those communication channels is going to be essential for what we're currently doing and for building a more robust ecosystem in the future. So thank you, and looking forward to the Q&A.
Thank you so much, Mark. And for our final panelist, I'd like to invite Dr. Barbara Evans, who's going to discuss the desire to use and fulfillment and trust.
Thank you. I was involved primarily in the National Academy's section on factors that affect the willingness of physicians, the healthcare system, and patients to use AI diagnostic technology. A key issue, of course, is whether they trust that the technology works in the sense of being safe and accurate, but also in promoting core values of healthcare, such as patient privacy and equity. And there's always a trust issue with the concern that any new technology could cause unexpected new liabilities. On the question of safety and accuracy, FDA issued a final guidance on clinical decision support last September, but it left some questions that will be resolved in the future. Also, a guidance document such as that one is only advisory, and it doesn't set any binding rules that you can count on the way a regulation would. So this makes it hard for physicians to intuit whether a given type of diagnostic or clinical decision support tool is or is not subject to FDA safety oversight, and how rigorous and data-driven that oversight will be. So when a new tool arrives in the clinic, can you assume that FDA has reviewed data showing it's safe and effective? Do you know who it's effective for? Is it just for white males, or does it work for all the rest of us? Or did it come to market under a less rigorous process where we're waiting on post-market evaluation to see if it's safe for your patients? Right now, it's hard for clinicians to have a clear intuition of what the regulatory baseline is, and that obviously is something that undermines trust. I want to note that FDA's heavy use of guidance documents can be completely appropriate in the early stages of a new technology when learning is happening and everything's evolving. But at some point, you need clear federal regulations so that healthcare institutions and the states can rely on what the federal government is doing so they can build out their own policies and state laws and regulations. The GAO concluded in its report that limited data on real-world performance is a major issue affecting trust. And here we have a chicken and egg problem. We can't get AI diagnostic technology into the clinic until it's being reimbursed, but you can't get it reimbursed without some good evidence of clinical effectiveness and utility. And you can't get that evidence until it's more widely used in the clinic. So it's sort of a circular startup problem. Diagnostic technologies, even the traditional ones that we've had for 50 years, have always faced a really challenging reimbursement environment. Healthcare payment systems tend to favor therapeutics, and diagnostics are the neglected stepchild. But we're at a time when advanced diagnostic technologies like genomic testing and like AI DDS systems have the potential to improve patient outcomes and make our use of treatments more targeted and better effective. What we need is a value-based reimbursement framework that takes account of the value that a good, accurate diagnosis creates. And we need a mechanism that's like coverage with evidence development, where we can go ahead and start paying for a technology even as we're doing further clinical evaluation on it. I want to caution, though, that the reimbursement frameworks we've traditionally have not produced equity. And we widely agree that equity is a key consideration that will drive acceptability, trust, and desire for this technology. We need some sort of safety net for the uninsured to make sure that they have this technology, and also to be sure that we're gathering evidence of how well it performs for them. So a big question is, what does a safety net for AI diagnostic technology look like? Is it a data commons, a national infrastructure, public funding such as grants? Is it pilot projects? We need to keep in mind that rethinking equity probably does not mean simply replicating the payment systems we've relied on in the past, because they did not produce equity. With my remaining time, another major issue that we're all concerned about is privacy. And here we need to understand that using our data in AI diagnostic decision support is a clinical use of data. It's not a research use of data. We all tend to think in terms of the research ethic norms, such as informed consent, IRB review, where each person protects their own privacy by limiting access to their data. But that's not the privacy framework we have ever used for clinical data privacy. In the clinical setting, we assume patients are sick and vulnerable and may not be able to get the care they need unless they share their data. So medical privacy law has always used a duty-based scheme where we put some stringent confidentiality requirements on the data handlers, such as the clinicians, the healthcare systems, the insurers. And this is reflected in state laws like Medical Records Act, licensure requirements, and health laws. We need to enhance that framework, the confidentiality framework, because AI decision support is bringing a whole lot of new players into the treatment encounter, such as an IT professional, a software vendor, and the AI itself. Many of you may be of a vintage such as mine, where you remember the book Strangers at the Bedside in the 1960s that talked about how disruptive it was as we moved from a family care provider model of healthcare to multidisciplinary teams of healthcare providers. We're in something similar to that now. The strangers at your bedside are about to get a whole lot stranger. They may include an AI. And we need to take account of how do we put proper confidentiality duties on every party who's involved in treatment. The final big issue is liability, which is also a matter of state law. Everybody wants accountability, but nobody likes tort lawsuits. But in our legal system, that's one of the main ways you enforce accountability. Clinicians rightly fear that all the liability is going to end up on their shoulders. But there actually are some opportunities here to rethink how we apportion liability and responsibility as between the physician who's using the tool and the software developers and vendors who made it. I'm out of time, so I suggest we would defer that topic to the question and answers. My conclusion is there's enormous promise here, but we have a whole lot of work to do to get all of the legal and professional ethics frameworks in place for this to work well. Thank you.
Thank you so much, Barbara, and thank you to all of our panelists. With that excellent introduction to some of these key barriers to adoption of AI tools in practice, we're going to transition now to about a half an hour, 25 minutes of a moderated panel discussion. However, all the while, I'd really like to encourage the audience members, please start putting questions in the chat. We do have some pre-prepared questions, but certainly also want to prioritize and make sure that we address any questions that you might have. So our first question to get us started with the panel, and I'm going to direct this to Dr. Gonzalez to start us off, but I'd like us to consider for a minute that right now we see AI tools being developed in many different contexts that aren't actually mapped back to solving an actual clinical need. We've heard many of our panelists touch on that topic, but I wonder what your thoughts are about what we can do to ensure that the new tools that are developed are truly aligned with the missions and priorities of our complicated system. So health systems, providers, and the patients that they're meant to serve. So Andrew, would love your thoughts to start us off, and then we'll ask others to chime in.
Thank you. That's a really great question. I think that, this is sort of the perennial challenge in any sort of technology development is how exactly do you make sure that there's alignment amongst stakeholders? In my opinion, it's ensuring that everybody is brought to the table, not necessarily in terms of each individual person, but certainly in terms of categories. And I think making sure that that view is expansive. So obviously patients and providers are sort of the core, the nuclear family of, this idea, but the health system also matters because they have a lot to do in terms of implementation of that. There also needs to be community engagement to make sure that what patients and providers view as a problem can be rolled out in other places as well. Making sure that that table is expansive is somewhat of the challenge because, you can invite individual people, in which case, some might argue that democracy breaks down when you get larger ends. There also may be stakeholder groups, but then there's a concern that these groups don't necessarily recommend or represent everyone. So it's a little bit challenging to figure out how to build that table, but that's essentially the way that this has to happen. The problem with the traditional model is usually it's a tech company that has a product for which there may or may not be a use, whereas we need to inverse that technology development pipeline. Part of it is a cultural change that is going to be challenging to deal with because I think we're always at loggerheads, and the move fast and break things mentality is not really the way that most clinicians or patients would really want to operate. And lastly, I'm just going to put this out as a personal view, is we all need to start getting away from the idea that there's going to be a medical AGI. Artificial general intelligence for medicine is a long way off, and we need to make sure that we're kind of focusing on individual problems for which there are identifiable stakeholders who could sit at the table, not we're going to solve all the doctor problems and then fire all the doctors.
Yes, please, Mark. Yeah.
Just on that last point, there's been some, I would say that it's been surprising for a lot of people, myself included, how like you may have heard of, I forget what the acronym is, but it's the Chat GPT. These generative systems that are very broad are really surprisingly useful, potentially, in a way that I don't think we should be discounting anymore. And I'm saying this from the perspective of someone who has almost exclusively worked on very narrow prediction tasks within supervised learning. I am kind of updating my own mental model to no longer discount general generative models, because I actually think what's happened in the last year, like, we all need to be paying attention to, because it's, I used to agree with you a year ago, and I don't know where I stand now anymore. And I've been trying to figure that out. So would love also other people's, I saw, Barbara, I've seen you nodding throughout this. So I'd love to see what other people think, because these things, as they come out, it really does change the way you think about, well, what's on the horizon.
Yeah, Steve, I see your hand up.
Yeah, my comment is that it's definitely important that everyone is invited to the table. And it's equally important when we invite people to the table. You know, oftentimes, for example, we ask, do you involve patients in the design of your product? And it's rare that they say yes, but if they do say yes, it's most often once the product has been completely developed, and basically is asking patients to test it and to refine it. But to the point of all of our panelists, Mark, talked a lot about problem formulation and problem selection, for example. We need to involve all stakeholders, including patients, at the earliest stages of problem formulation, so that we make sure that we develop tools that actually are in the service of patients. So that's also important. It's not just who's there, but also when we invite them.
Yeah, Barbara, did you unmute yourself because you wanted to add something? I want to allow for you to speak.
No, I think I had not muted myself afterward. I can add that I think the general AI is going to replace the lawyers before it replaces the doctors. I'm not sure that's good for doctors, though, if it's smarter and finds better ways to come after you.
Thank you, Barbara. Cornelius.
Yeah, I just wanted to kind of piggyback on one of the things that Stephen just mentioned as far as the timing of those collaborations. I think it's really important. Unfortunately, what tends to happen is, we have an idea or we have a problem that we want to address. Now let's kind of get together as developers and or clinicians and researchers and ethicists and so on to potentially address that problem. Whereas having firmly established, and I know that this isn't possible for everyone, but having firmly established collaboratories that are kind of ongoing, that are meeting on a weekly basis or a monthly basis, I believe that fosters, that collaboration, so that again, we're not kind of waiting until we get to a certain point where we start to kind of collaborate and listen to some of the things that are being discussed, but we're kind of addressing some of those things, or at least thinking those things or putting those things into the minds of the developers and or the clinicians and so on before we even get to or start to address a particular problem.
Yeah, thank you, Mark.
And so two things I wanted to add to the topic of how do you align kind of the opportunities that you go after with the kind of types of solutions. So one thing that we've observed with the interviews we've done across sites is that it really does differ when you look at, like, everyone on this call, we're all at academic medical centers. So we all are in settings where there are people with internal and external funding to build solutions to these problems. But the majority of healthcare is provided in contexts where there's not internal developers. And I don't think, reasonable expectation that there would be internal teams building solutions that are then considered for adoption. So I think it's just really important to keep in mind the context. Most systems are reliant on external suppliers for solutions. And so you don't quite have that mismatch of having research funding to fund an implementation that hasn't gone through like the organizational prioritization. And then the other thing about community involvement, I would say that's a place that there is one site. I mean, the site that sticks out that we've interacted with is Sick Kids in Toronto. And I would say even in that setting, I feel like the reason they have better infused community participation in their AI implementation process is because it's a pediatric setting and because there's additional complexities for kind of visibility into the tools used internally. But I would say that's an area where there is we have not seen good best practices with it in the US really. And it's hard though, because when we ask health systems, what should this look like? I think there's a lot of uncertainty of, does this happen at the algorithm level for every procurement decision? Does it happen at the level of setting priorities for the organization? Do we leverage existing patient advisory groups? So, and I'm really kind of open and eager to learn how people are approaching this, because I think folks are getting pressure to be more transparent, and myself included. Like, a lot of us work on algorithms that there's not visibility into for patients in the community. And it's hard to know what the right level and type of engagement looks like.
Absolutely. Thank you, Mark. I have one just very closely related question from the audience. And then there are a lot of questions coming in about some of the medical legal aspects of AI. And so I'll ask the group, I thought this was insightful. While discussing the issues around adoption in a world where AI is fully implemented and used, how will this and the associated systems, how do you see this and the associated systems shaping the future healthcare workforce? So I'd be curious to know your thoughts on that.
Can I recommend Cornelius?
Yeah, absolutely. Cornelius, you want to start us off on that? Yeah, that'd be great.
I think so. One of the things that I've been thinking a lot about is this task work versus teamwork concept. Kind of thinking about, I'm actually currently writing about this, thinking about artificial intelligence. And I'll kind of use or look at it from kind of the perspective that Andrew is thinking about, from a not a generative where we're thinking about generalized AI, but we're thinking about AI more so performing specific tasks. I think if we start to look at it from that perspective, then I think we potentially tamp down or decrease some of the anxieties related to AI kind of taking over specific whole jobs, so to speak, within the healthcare workforce. I think looking at it more so from the perspective, at least in the nearer term, looking at it from the perspective of AI or artificial intelligence is a team member. And what is that team member? What task is that team member, or are that team member, can that team member address that could potentially decrease or minimize some of the burdens or the cognitive, whether it's cognitive or time burdens associated with clinical care, that would free up clinicians and or other members of the healthcare workforce to do things that they are more suited or better suited to do compared to an artificial intelligence agent. I think that's going to be an important consideration as we start to look at it more so. And I'm sure many people have kind of heard this phrase, augmented intelligence, as opposed to just like the AI kind of taking over everything that a clinician does.
Yeah, Steve?
Well, I think, when I think about what's shaping the direction of healthcare and then therefore the healthcare workforce, I think that there are much larger macroeconomic and structural forces that are at play that is moving healthcare in the way that it is. And AI, I think, is either going to augment our ability to deliver that sort of future healthcare or impede it, and hopefully augment it rather than impede it. But I'm thinking about how in the last decade or so, we have seen care shift significantly from the traditional episodic, synchronous, office-based care model to a continuous, asynchronous, hybrid, if not virtual first model. And that is a very, very significant change in the way that we're delivering healthcare and in the way that we're going to have to prepare our future healthcare workforce to be ready for that type of care. The role that I see AI in this sort of equation is whether or not it's able to support that type of continuous, asynchronous, hybrid care that we're all applying, both in the outpatient setting where most of this stuff is happening, but then also increasing a lot in the inpatient setting as well, where these forces are affecting inpatient, brick and mortar hospitals in certain ways. For example, in the decentralization of care teams, you think about EICUs and telemetry and care transition programs, for example. So I'm excited to see how AI provides the tools that we need in order to support that type of care, which is really not driven by technology, but driven, I think, by, again, larger macroeconomic and structural forces.
Yeah, thank you, Steve. Mark? Oh, Mark, you're muted.
Sorry.
There we go.
I was going to say a change that I am still kind of waiting to take effect. And so in many ways, I was at Duke at the right place at the right time in my career. I was a medical student when the team that I work for today was created. But even in the decade since I've been at Duke, there has not been substantial increases in the number of internal R&D teams within health systems building products and services for their frontline clinicians. And most AI and ML work is still carried out primarily as a research function that's externally funded. And I've struggled because we run this medical student scholarship. Every year we bring in medical students, embed them on projects to work with frontline clinicians, to build products and services for frontline clinicians. But there's not many places we can point them to allow them to continue to do that work. And I think a lot of this relates to business model and how these, like Barbara was mentioning, kind of diagnosis is not paid for in the same way. So if a health system does better at diagnosing something, it's not like they can fund that workforce. But I feel like it needs to evolve over time, where we take these highly skilled professionals, but have them work. And I know Stephen's involved with ABFM, putting together dyads of clinicians and technical experts to be building these tools at the front lines. And it's something that we need to do a better job of disseminating. And we're fortunate at Duke to have the capability here, but there's not enough of it happening.
Yeah, thank you, Mark. Andrew, I see your hand.
Yeah, I just wanted to very briefly add to it. This is actually something that Cornelius and I had talked about before, is that, we also have to come up with two systems to augment the workforce. So one has to deal with people who are already in practice to sort of bring them up to speed. And the other thing, and I'll take full responsibility for this comment since it's a little bit controversial, but I do think, as we've gone a holistic review for medical school, we need to reframe what the entry requirements would be. Looking at US News and World Report, approximately 60% of matriculants are science majors, biology, biochem, neurobiology. When you look at, who are engineering or CS majors, you're talking about like less than 5%. And maybe as we push forward, we should consider reprioritizing that, because as somebody who rounds every day, very few times I've been like, what the problem with this patient situation is? We just don't know enough biology.
Yeah, that's interesting, Andrew. Appreciate that. Cornelius, or no, I thought I saw your hand raised. All right, well, so why don't we shift gears? I did, again, in the chat, I appreciate the questions. And Barbara, I'm going to direct some of these questions to you to get us started. So the first question from Deep Woo is, what are the legality, I'm assuming, of persuasive language that might be introduced by AI and NLP? And are there legal examples of precedents on this topic?
Well, I have to apologize. I'm not familiar with what is meant by persuasive language. Could you tell me what is meant by that?
Yeah, I think, Dee, I see you in the chat if you wanted to add in a clarification. But I think the idea would be, if the AI or this is the way I'm interpreting it, at least, is if the AI or the natural language processing tool is providing feedback or something that's going to persuade people to do something, is there any legal precedence for how you might handle that if a clinician or somebody takes an action based on that recommendation, or they were persuaded to take an action?
So it could be something like a warning where the AI says, don't do this, because I think that would be relevant in a suit against the clinician to show the state of mind that the clinician was aware of a risk or was going against what seemed to be advice. I don't think it would necessarily be more persuasive in court than any other information that had been provided. But I hope the person who posed the question will correct us if we aren't understanding what they meant by it, and we'll go at it again.
Yeah, and Dee added, for example, giving advice to a patient. So kind of giving that advice.
So the AI is directly communicating with a patient?
Or proposing a guidance or advice.
Mm-hmm. Well, in the clinical setting, the usual model is the AI tool would be intermediated by the physician. And so if the physician is passing on advice, I think that becomes the advice of the physician. The legal framework is a lot less settled for AI that would directly provide diagnostic or clinical support directly to layperson patients. And for that, I think FDA is much more concerned to regulate it more stringently because the person doesn't have an intermediary who can help screen out bad advice.
Yeah, great point. I have two other related questions that are related to liability. So one, are there any examples or case law that address how liability is apportioned between physicians and AI tech, or will and how does an AI tool become a standard of care?
We did a pretty careful search as we prepared the National Academy of Medicine discussion paper, and there is some case law that, if not directly involving this situation, is clearly relevant, and we cited that and talked about it in the report. However, we're all aware that the liability framework is still at a very early stage of evolving because we haven't had a lot of litigated cases where a patient was injured, there was reason to believe an AI had helped cause that, and the suit was filed and taken to its ultimate resolution. That said, there's a lot I think we can infer at this point. First of all, there's always been, with all types of medical devices, a division of responsibility between the physician, who can be sued in malpractice for ordering the use of a device that injured a patient, and the device manufacturer. Traditionally, software developers and vendors have been very effective at escaping liability on various grounds. One of the most notable ones was they'd say, we're not a product. You can't sue us for product liability. We're an information service and don't fall under that framework. The interesting thing is that when FDA has moved in and is starting to regulate software as a medical device, clinical decision support systems, that makes it, for legal purposes, be a product, and it opens the door to product liability. That could cause greater scrutiny of whether the physician who used the tool or the maker of the tool should be held accountable, and they, in many instances, both can be brought before the court. But a few things that are pretty clear, and it shows how complex this is. Whenever a product is labeled for a certain use and a clinician uses it other than for that use, the liability will go to the clinician. This raises a complex problem. We want medical software to be better labeled, that this was trained only on this population and caution should be used before you use it in other populations. We want clear labeling to help the clinician know if this is likely to be biased. But when we put that labeling on the software, we're putting the clinician in the position that they have a choice if they want to use it on a patient other than the people who were represented in the training data. Are they now taking on all the liability? And that's probably not a good outcome, because we want to push some of that liability for biased, non-representative tools to the developer and manufacturer that perhaps should have had a more inclusive training data set. So it shows these dilemmas that are going to emerge. We have to take a holistic approach, looking not just at FDA regulation, but how it affects the state liability framework and how they interact, so that we can get a globally good policy.
Yeah, thank you, Barbara. Andrew, I see your hand up.
Yeah, I was, that's really great comments, Dr. Evans. I think that the other part of, I guess, the second half of that question was, when will it become the standard of care? And I think just to address that directly, it's sort of like when we all start using it. Remember that AI is just another tool. When you take any technology development implementation, it becomes a standard of care as it gets increasingly adopted and more medical societies sign on and say this is what we should use. It's sort of the same thing like when endovascular aortic repair happened and everybody was doing open surgery before. Now we would argue it's the standard of care because it's the board answer and it's generally used. But I think that the fear that AI will become required from the standpoint, from like a business standpoint, may be a little bit different than from a patient safety standpoint, than from a liability standpoint. I would argue that part of the difference between AI and other tools is the autonomous aspect of it. So the product liability is kind of the same law all around, but the autonomous nature of certain AI systems is what makes it a little bit different. So all of these sort of sentinel programs that look through radiology reports to find this finding or that finding, if decisions are based on that, makes it somewhat different. But I don't necessarily know that clinicians should fear that failing to use an AI is going to somehow result in liability from that standpoint.
Yeah, thank you. Barbara, I'm sorry,
Yes, we seem to have a system freeze up. Are you able to hear me?
now we can hear you, yes.
Yeah. I think this raises a really good point, Andrew's comment, and that's as these systems become more commonly used, they will be offering some advice, but I wouldn't expect that courts would view the advice these systems provide as definitive proof of what should have been done. We see the same thing with well-established clinical practice guidelines. Because a doctor goes against a clinical practice guideline, that doesn't mean the doctor will be held liable. The guideline is merely some evidence to inform the standard of care, but it's not conclusive evidence. So the difficulty is going to be getting these issues in court, and everyone's trying to put the advice in perspective and challenge it, when so often these systems are not terribly transparent of how they got to their advice. But I wouldn't be concerned that merely because a physician disregards an instruction from an AI, that's going to be an open and shut case of liability. Nothing works that way in medical liability.
Yeah, thank you. Cornelia, oh, Mark.
Oh, Cornelius can go.
Okay.
Oh, no, I was just going to say, I think Barbara pretty much hit the nail on the head with that. But, you know, as she kind of brought up, you know, clinical practice guidelines, I will say, you know, it is interesting that, you know, clinicians, you know, even in training, you know, we are responsible for being able to, you know, interpret, read, be familiar with clinical guidelines, the most up-to-date or relevant literature, you know, and I do see, yeah, I do see or can appreciate the importance of clinicians being able to do the same thing when it comes to the output of an AI algorithm. So to be comfortable with or familiar with that clinical practice guideline and to be able to appraise that clinical practice guideline, I think similarly, clinicians are going to have to be able to appraise and or interpret and or apply the outputs of these algorithms, and they will be responsible for their ability to do that in clinical practice.
Yeah, so to like one line that I would say, I appreciate the time to flex the legal muscles again, is it will never be dispositive, but it may switch a rebuttable presumption, meaning that if you fail to do a clinical guideline or fail to use AI that everybody else is using, that may shift the rebuttable presumption toward the other side, but you can always fight it. But I think the concern that you didn't listen to the AI, so you're automatically wrong, is never going to happen.
Thank you for that, Andrew. Mark?
So one of the questions we got recently from a health system we're working with is And this is a concern that I think is shared by a lot of health systems. So within the last month, there's been new legislation going out to increase transparency and access that patients have to their medical records, and to limit the information that's in the medical record that is not provided to patients. So as I'm sure anyone who's kind of built or run an algorithm in production, like, you're writing a lot of algorithm outputs into database tables. Many of those database tables may or may not be visible to frontline workers. If there are things that are visible or presented to frontline workers, it's often a subset of all of the outputs being written into the medical record. And so there's a lot of concern now that on one end of the extreme, you may be doing a prospective study, just doing a silent trial, not even exposing the algorithm to clinicians, but now there's records of the algorithm outputs that patients may retrieve, that they could say, well, okay, there's record of this, why wasn't this intervened on? There's also going to be cases where the clinician did see or was exposed to some of the information that's written in the record and decided, as we've been talking about, to either pursue some other action, or their recommendation or intervention did not align with what was documented by the algorithm output. So I'm curious too, because so much of the complexity happens when you have these tensions. So on one hand, we want to increase transparency and visibility that patients have into their medical records. We're also trying to do more rigorous studies where we are evaluating systems locally on our own patient populations before implementing them clinically. So that creates this kind of fragile scenario where you have creation of data that is a little bit sensitive, and health systems aren't fully equipped to defend if they're asked to by patients. So I'm just curious, folks who've thought about this, because these problems change, like literally month to month, there's new dimensions.
Barbara.
Assuming this is going on at a HIPAA-covered facility, patients will have a right of access, and there are ways you can manage what gets into the so-called designated record set that is returnable to a patient under that right. One thing is, if you don't need to keep data identified to a particular patient, don't do it, because when it's identifiable to them, it's part of their designated record set. And the other thing is there's some things you can do with segmenting your databases so that you are very careful about, is any part of this data set being used to make decisions about patients, or is it purely for research? So there's a lot of data management and data storage management that needs to happen here. This is not dissimilar from the issue that came up with some of the byproduct data that's generated in genomic testing that has the potential to be confusing and not clinically significant. So this is just another thing to put on the list, is managing the HIPAA structure of databases. It needs to happen here.
Barbara, one of our concerns though is you need to be a high resource setting that's super savvy in the way that you implement your model and has separate data infrastructure for that collection. I mean, by default, if we take the EHR vendor that is most prominently used at academic medical centers, the default way to prospectively study an algorithm is by writing outputs to individual patient records. So we're also, I saw the question in here about ethics. What we're trying to parse is when low resource settings are almost forced to make decisions that make them more vulnerable to using lower quality products or not validating in the most responsible way. It's how do we help reorient that imbalance?
I think that's a long conversation that we need to have. I don't think we're going to solve that in the next 5 minutes, but I'd be happy to learn more about it. And it's just a data management strategy. And sometimes there's real decisions you need to make about, do you want to write that into the record or not? Is that the right thing to do? And so if it's low quality, non-clinically actionable data.
Yeah, and I think that was a perfect segue also into this idea and this concept of ethics. And if we can shift it, I agree, we're not going to solve that in this panel today, but it would be interesting to hear your thoughts about what the roles of the different stakeholders in this work could be in addressing threats to justice, equity, diversity, and inclusion. So what are the role of the people who are developing the technology? What are the roles of the health systems for adopting the technology and implementing it? What's the role of government who's regulating it? We'd love to know some of your thoughts about that. Andrew, do you want to start us off?
Yeah, that's a really great question. I think, as we march toward equity as a guiding principle for, where healthcare in the future is going, we first moved toward quality, then we moved toward cost. Now we're apparently co-optimizing those and calling it value. But as we move to equity as being a guiding principle, I think, getting everybody to the table is very important. And I think that may change the way that we fundamentally do business. I think that, to the extent that there's the healthcare aspect, there's the community aspect, there's the developer aspect, that ensuring that when technology is being developed, that people who actually have the disease for which this technology would be used, as well as the physician as sort of like the end user or the end implementer of this, have a seat at the table, as Stephen had mentioned, at all points during the life cycle, is really important. And that's not inconceivable when you look at other things like, I don't know, whether or not it's arms manufacturers to race cars to, I imagine, firefighting equipment. They ask the people who would be the end user of those for their input at all points. And I think ensuring that that includes community members as well as people who would actually be benefited or hurt by this technology is something that we could add that would make it different than what had been going on before.
Thank you. Cornelius?
Yeah, I agree with Andrew. This is definitely a responsibility of everyone involved, but I was just kind of thinking, as we've been emphasizing the importance of collaboration when it comes to all of the various stakeholders, I think it's important to kind of acknowledge, and not that everyone is not well-intentioned. I think people are well-intentioned, right? Or we want to do what's best for the patient and everyone involved with healthcare, but we're talking about potentially different ethical and professional standards and guidelines and so on that are coming into practice here. And I just think that's something that we're going to have to kind of keep in mind with or wrestle with or address in the future when it comes to these individuals from these different professions. Again, certainly well-meaning and well-intended, I'm sure, but there are some differences there when it comes to I don't know if everyone's talking about beneficence and malfeasance and so on. There's certainly things that we talk about often in medicine, but is that a thread that kind of weaves its way through all of the other stakeholders that'll be involved with the development of these models? I just think it's something that's important for us to keep in mind.
Absolutely. Thank you. Mark?
So a lot of the work that we're doing now kind of focuses on this question of the digital divide, where the institutions, the folks on this call are a part of. Like, we are in many ways defining how these systems are built within these highly resourced environments. But the disconnect, and I'll be very concrete here, is the most broadly used algorithms are often directly from the vendors of the EHR systems that have questionable quality. And Cornelius has colleagues that have helped bring to light a lot of these concerns. And the Epic sepsis model last summer, I think, was kind of a turning point. And we've seen FDA come with the guidance. We've seen Epic say that there's now kind of a new way that the sepsis model will be built with local configuration. So that point of settings that don't have the internal capabilities are more reliant on these suppliers. And you have this gap of regulatory oversight where there's not some trusted intermediary to conduct evaluations. So I mean, the quality of care will further divide. So that's the piece of the ethics of adoption that we're most focused on right now. And one of the biggest challenges is the highly skilled, complex, interdisciplinary nature of doing this work effectively. And we've tried to look at different kind of models, and I've talked with Cornelius about this. Like, there's a very prominent model called ECHO out of New Mexico called Extending Community Health Outcomes, where how do we take these models where specialized centers of expertise can extend their expertise to lower resource settings in their geography or in their catchment area. That way they can elevate level of care across settings. And I think that more of that learning network collaborative model is what's needed, because it's infeasible that every organization will have an AI ethicist. And there's actually very few that do. We've encountered 2 in our interviews, and if there's more, if there's a pipeline for them, we need them. But that's going to take many years to solve.
Yeah, thank you, Mark. Steve.
Amelia, I think the short answer to the question of who's responsible for equity is all of us. The harder question is, what can each of us do? And that's very difficult. So one of the groups that I'm involved with is a National Academy of Medicine Consensus Study Committee that's working on developing a equity-focused cross-sectoral governance framework. We're thinking about where are the choice points across the life cycle of technology innovation, all the way from problem selection to post-market surveillance, that individual stakeholders can do, whether it's a hard or soft governance lever to advance equity. So with a stakeholder group that is as broad as academics, venture capital, researchers, technology developers, government, of course, patient advocacy groups, disadvantaged communities. It's very, very difficult to know exactly what we can do to advance equity, yet we have, I think, a moral imperative to do so. So that report will be hopefully released in May of next year, and will hopefully provide a framework for thinking about this. And lots of people, including many on this panel, have been thinking about equity. I think we're in the nascent stages of being able to deploy some of those equity-focused frameworks in real life, but still a lot of work.
Thank you, Steve. And I want to invite Barbara and Cornelius. I'd love to hear your thoughts. One question from the audience that I think will help frame the ongoing discussion is, if somebody can just briefly, I know this is briefly describe when you are discussing equity in this context, how would you define it? So either Barbara, do you want to go next and kind of lead with just your concept of equity as we're discussing it?
Most people talk about this, and I think the key core concept we have in mind is that AI tools may perform less well depending on demographic populations, and that is put under the name bias. But the reality is there's so many different forms of bias. You know, it is a term that just expands out into, it has many causes. It's just a multi-headed hydra. Sometimes the bias is just that the data that were used to train the system accurately portray bad care practices from the past that caused women who showed up with a sore chest to be sent home until they had stress instead of being admitted for a heart attack, and that gets baked in. You know, it's just a past problem that's reflected accurately in the data. Another problem is selection bias, and this is a big one, and it kind of runs against our notions that people should only be in these systems if they consent. Well, consent creates biases of its own. And how do we address that? How do we make sure these data sets are inclusive? I think, though, the bottom line we're all getting at when we talk about equity is this fear that these wonderful tools will work well for a select group of patients, perhaps predominantly male, predominantly white, predominantly treated at high resource academic medical centers, and they won't work so well for everyone else. And that's a real civil rights issue. It's an invidious form of healthcare discrimination when it happens. And I agree with those who say we've got to do something about it. The comment I was going to make, though, is that we need to be cautious that we understand what the inequities look like. We don't want to rush to strategies to solve it until we understand the scope of it. We need to be doing a lot of monitoring of clinical performance of these tools to see, do they or don't they produce these disparate outcomes. I was surprised to hear a talk the other day. It was a tool that had been trained on a 85% white women in the training data, but it worked really well for everybody. We don't yet know which medical phenomena vary according to demographic and socioeconomic traits, and we need to get a better handle on it, because ultimately we're all one family of humankind, and we may be more alike than we are different, and we need to get a better sense of which things are part of the human tribe and which ones we need to be really careful about. And that's a scientific problem. We just don't know enough about what is causing these variations, and we need to be doing the basic research to detect it.
Thank you, Barbara. Cornelius?
Yeah, I'll be really quick. I was just going to say, I think there's two issues here when it comes to AI and the equity piece. There's the access part of this, meaning, will populations even have access to some of the potentially amazing algorithms that are being developed out there? And I think Mark was kind of alluding to that, given that we're, at academic institutions and so on. So there's the access, but there's also the opportunity piece. Does anyone who's basically even in an environment where the algorithm is available or the model is available, do they have equal opportunity to have that resource? Do they have equal opportunity to benefit from that resource? So I think there's kind of two pieces to it when it comes to equity, in that there's the access to it and there's also the opportunity to benefit from that access to it. But I was going to also say one other piece that I wanted to just throw in there was when it comes to what developers and researchers and government and so on can do. I think it's really important that the developers we have a diversified group of developers, researchers, clinicians. I think across the board, generally, we need to be working toward making sure that we have a diverse group of individuals and there, people from marginalized communities, historically marginalized communities, doing some of this work, because unfortunately, what tends to happen is that sometimes that work doesn't get done if you don't have a diverse workforce in there actually focusing on some of these DEI issues. And not that it should all fall upon one group of people. Like we've said, it's definitely work that all of us should be participating in, but I think diversifying the workforce, making sure that we have more engineers and computer scientists out there from those historically marginalized backgrounds, physicians, clinicians, et cetera, extremely important in my opinion.
Yeah, thank you. One follow-up question from the audience that I'd like to just hear your thoughts about. So one of the questions, and I think one of the ways we learn about the biases in these algorithms, is once we put them into practice and people recognize that they aren't working adequately or they aren't working equitably. Are there any current guidelines or outlets reporting either adverse effects or inequitable effects of these AI tools? Thank you, Mark.
So quick comment on this is a few months ago, we were notified about the HHS had a proposed rule that covered entities, so hospitals, health systems, could be liable for discrimination that results from use of clinical algorithms. And there was a lot of concern from a lot of the health systems we were speaking with about, like, how do we even identify this? And so we started putting together kind of what were recommendations that we could build consensus around. And I'll mention the three, but one of them is that so if you're a health system that can locally validate the algorithm before it's implemented into clinical care, you should do that. If you don't have those capabilities, the vendor should support you in doing that. And we do think that a lot of the harms to patients can actually be avoided before these things are used clinically. And there should not be, I mean, there may be cases out there, but saying that you need to wait until something needs to be implemented, I don't know how true that is. And the great thing about these systems is that you can understand their performance before you need to expose them to patients. So that was the first recommendation. The other recommendation is we need to develop clear definitions for how to measure bias discrimination. There's many different computational approaches. They are not aligned. You can optimize one while not optimizing the other. So we need to have a common framework for how to measure quality. And like, if anyone has worked on quality measurement, when you are trying to define a CMS readmission, like, you are diving into 30 or 50 pages of PDFs. Like, I do this all the time for sepsis. It's really complicated. We need to have really clear, explicit documentation for how to do that for bias and discrimination. And the third piece was, we still haven't even done this for devices, pulse oximeters. So we should start with devices that physicians rely on more before we put the liability on the health systems themselves. So this is an area that also is emerging, and I think health systems are struggling with. Obviously, we all want to be responsible for providing equitable care and not worsening discrimination, but not every health system has the capabilities to do that. We don't actually know how to do it. And vendors are not organized in how it's being done in devices too.
Thank you, Mark. Anybody else have anything to add about that last topic? Oh, Steve.
Agree with everything Mark said. And I don't think it's a secret to anybody that there are gaps in the FDA's post-market surveillance program. So you cannot address issues of equity through the current system of voluntary reporting and spot check audits. They're barely adequate for evaluating the safety of approved drugs and devices, much less the inequities that the use of those drugs and devices cause. So, and we're talking about, emerging technologies that we're not equipped in our current regulatory ecosystem to manage. So I think the future really has to be a modernization of the FDA post-market surveillance program to include, beyond voluntary reporting and spot checks, real world data to be able to actually see patterns of inequities that are emerging from the use of drugs, devices, and AI algorithms.
Thank you, Steve. Andrew, I know we have 2 minutes left, so Andrew, I'd love to hear your thoughts, and then we'll close the session.
I would actually just say that is probably a potentially huge unrecognized source of liability. I think outside of the medical legal context, if you put it in a product's liability context, another question might be, what happens when a AI company knowingly has a non-representative data set, but then markets it to people who were not included in the data set, knowing that harm could happen because their training data was biased? I think, that falls into kind of the product's liability area, where the actual big numbers, as opposed to medical legal liability from a malpractice standpoint, are. Most lawsuits are not medical legal in a negligence standpoint, but are like McDonald's suing Burger King over the fact that the Big Mac and the Whopper are basically the same burger. That's where the real millions are.
Thank you, Andrew. Well, I realize we're at the very end of our session. Thank you all so much for being here today. I can speak for myself, and I'm sure for the audience that we learned so much from each of you. So thank you so much for your time and expertise. And I hope you have everybody has a wonderful rest of your day and enjoy the rest of the conference.